Thank you, everybody. We're moving on to our second session now, and following on from Richard's session, we're going to look at, we're going to do a deep dive into what does the digital layer need to look like in the neighbourhood team. So I have a wonderful panel, and I'll just quickly explain how we're going to run this session. We've heard that digital needs to sit at the core of all of the new neighbourhood teams, the neighbourhood processes, the IMTs. What does this digital layer need to look like? How are we going to build it? What have we got that is working well at the moment? And where do we need to go in terms of improving it, making new systems? What are the barriers and challenges that we currently have? So we're going to look at it in terms of our data. How do we turn our fragmented data into integrated data? How do we stop having data silos so that people can share it properly? How can we look at coordination instead of activity? And most importantly, moving from what we currently do a lot of, which is episodic care, into more population health management. Because ultimately, if the neighbourhood teams and the neighbourhood systems is going to survive, it's going to be based on the impact we make on our populations. So we're a little bit short of time, so I am going to run through things a little bit quicker than I was anticipating to. But I'd also like to leave a bit of time at the end for audience participation, because I know that with our fantastic panel here, there may be some questions that people would like to ask. So if I could just start by getting our panel to introduce themselves very briefly. Aruna, can I start with you?
Hi everyone, Aruna Garcea. I'm a jobbing GP, first and foremost, and an Associate Medical Director for Primary Care in University Hospitals of Leicester, and also the Clinical Lead for Neighbourhood in our ICS, and historically have also been a CCIO within our System Federation in LLR. Thank you.
Thank you. Charlotte, can we move on to you, please?
Yes. Good morning, everybody. I'm Charlotte Williams. I'm the Deputy Chief Executive of North West Anglia NHS Foundation Trust. I'm an acute person in the room.
It's fine.
I'm the board member for digital have responsibility there, and also for innovation and transformation. And I lead for partnerships, and we host our place arrangements. So we host our integrated neighbourhood teams for the North Cambridgeshire and Peterborough area, and also being part of the Neighbourhood Pioneer Programme in Peterborough and Fenland.
Fantastic, thank you. And moving on to James.
Good morning, my name's James and I'm a GP, and I've had a shave. I'm a clinical professor in the School of Medicine at the newly named University of Lancashire, but I think I'm here for three reasons, or three roles. Currently, I created and chair the Digital Clinical Excellence Forum in the UK. This is the network of the independent online providers. Many of services exceed that of the NHS, and many people are using that more than the NHS for digital services. I've just started a role to help develop neighbourhoods in the Northwest region. So we've got a network of 20 neighbourhoods, so we've got some good insight into the challenges that they're having. And then finally, I've just finished a 2-year piece of work with the Ministry of Health in Singapore, and we've now passed legislation on the regulation of AI. So as UK is sort of catching up on the regulation, Singapore have completed it. So some insight on that too.
Lovely, thank you very much. So if I could start off by asking our panel, from their lens, because obviously we've got three very different views and sort of involvement in the integrated care systems from our three panellists, what does the actual digital layer look like for the integrated care services, or for neighbourhood teams, or even at PCN level? Aruna, can we start with you as to what you think that layer needs to provide for the workforce?
Thank you. It's a really good question. And I think that sometimes we just need to think about what we're trying to do within neighbourhoods, because that's essentially what we're looking at. And I think with neighbourhoods, critically, it's about integrated neighbourhood teams and how do we enable them working together. So if I go back to, for me, there's three things. One is interoperability, which we've heard loud and proud, I think, from everyone on the panel this morning, and I'm sure every one of you, because I'm preaching to the converted, and of course in the bill. But it cannot go unsaid in terms of the importance for continuity of care and in terms of management of complexity. I think the second thing is data. With that interoperable record comes a data set that is common to all, because every time data crosses an interface, we've got another interface that we're crossing, if that makes sense, and the patient's crossing. And that's where we have multiple sort of churn of resources, of processes to try and get people across the line. That's on us. That's not the patient, because the patient needs continuity of care. And I think thirdly, that digital layer, for me, critically, is actually about the unit that's binding everything together, which is the fact that we need to rethink the care plan. So it's not just a simple care plan, but an aligned care plan and a patient-held care plan with absolute mandated personalisation that is inclusive of the community and inclusive of carers and VCFSEs. So we need to understand, I think, as a digital community, how we're going to deliver that within neighbourhoods.
Thank you. And Charlotte, from your point of view, from the acute lens, because obviously you're not going to be as integral to designing those pathways, where do you see the data that you hold in the acute trust? How does that fit into what we're trying to design?
Yeah, I think there's a few things for me around this from a hospital's perspective, and we're a hospital group serving a quite disparate population across Lincolnshire and Cambridgeshire. I think that firstly, there's the opportunity for us to change and how we can use our data to achieve the goals of the 10-year plan. So if we zoom out from that and think about the 3-year plan and the years beyond that, we need to understand over the longer term where the evidence is for those reliable changes in resource to support the population better. So I think something which is actionable from a planning perspective for service redesign, because it takes us time to change, and for all the reasons we heard, outpatients still being delivered like it was in the 70s, how are we actually going to materially change the shape of care in the patch? And that's about having that data that works and puts things in the right place. That only happens if we bring all of our information together and have the right logic to understand that in context of the evidence. I think the second thing is really the sweet spot of neighbourhoods is doing the extra bit that isn't just the care added together. So it's putting the person at the heart of that and helping us to understand both the patient preferences but also the nuances of the localities. We don't see that. We're serving a huge population. We tend to offer a standardised model of care. What we need to be able to do to meet the 6 elements of the neighbourhood model is to provide something more nuanced to people, their families and their communities. So how can the data that we hold in the acute sector be informed and populated with that? What we have at the moment, it even wipes the demographics off, to come through a standard referral pathway, let alone in the emergency setting. So I think for me there's a real richness there about how we can bring that data together and put people's own preferences and their own context into what hospitals do. And that'll help us to support those elements around complex care needs, supporting people at the end of life, and better preventive measures as well. And when we're seeing patients, we see over 1.5 million patients a year, we can have a big impact on that.
Yeah, thank you. And obviously, what we've heard from Aruna and Charlotte so far, a lot of that is based on episodic care and how we actually affect the care that our patients are having, or the delivery of that care to the patients. And I think, James, you've got some really interesting comments about how actually this relates to population health and the health of the nation is what is going to be the measure of success in this, as opposed to the episodic care that we're currently experiencing. Do you want to give us some comments about, from your lens, what does this neighbourhood process look like?
It's interesting with the neighbourhoods we're working with, they say there are 20 across the northwest at the moment. When we say the word digital, people mean different things by it. Absolutely. So we're not. It's become increasingly broad and imprecise because we've had telemedicine, telehealth, virtual care, digital therapeutics, and it's an incremental process. I mean, from the importance of where it started in 1992, I had an Intel 286 processor that digitized prescribing. So there's been an incremental process, but where we've got to with neighbourhoods is how we utilize information. What is the digital impact to analyze the need of their registered populations and deliver care against that need? I think too often we default, certainly in the work we've done in Singapore, we looked at 3 levels of digitalisation. There's the most basic level, which we sometimes always fall into, the operational and administrative functions, workforce scheduling, inventory management, those sorts of operations. Then there's the clinical ops, which we get interested in around the electronic patient record, about clinical workflows, transcription of speech into text. But the most important is how we start to have clinical decision support. We see lots of neighbourhoods creating integrated neighbourhood teams, and they don't know who the teams are going to work with. And one of the issues that neighbourhoods are struggling with is understanding the debility of the patients they are working with, or people who are becoming patients, and then focusing their efforts and resources where there's greatest impact. So I think it's where population health has got lost, and with population health, population analytics, population health management, which are all different aspects, but understanding the analytics that show you where you are best place your resources. And what we're really struggling with is then identifying where there's the greatest impact. Now, we are seeing some AI tools coming in. I don't know whether any of you from the Southwest, but I've been working with some of the neighbourhoods down in the Southwest, and there's an example down there, Brave AI, have you come across that? Which is starting to look at the risk profiling of people who are at most risk of being admitted to hospital, and how then you target your resources to help them live independently in their communities. And the other thing to say about the analysis, neighbourhood policy is an NHS policy. It's written by NHS people, and it's to solve some of the NHS problems. Now, we know we're not going to solve some of the NHS problems by doing it just through the NHS lens. We have got to bring in the social care, all the other aspects of it. But if we don't demonstrate that we're moving to a better place with hospital bed utilisation, but demonstrating the value of neighbourhoods, neighbourhood care will fail. So the whole point of not saying this is just about hospital, but if we don't start with analysing the greatest ability, the greatest risk, and how neighbourhoods can allow earlier discharge, reduction of length of stay, keeping people at home, because if we do things to Mrs. Jones that allows her to get out to see her grandchildren, become more mobile, less frail, but she still goes into hospital 6 times with her infective exacerbation of COPD, neighbourhoods will fail. So the analytics of looking at those at highest risk, and particularly highest risk of unscheduled admission to hospital, readmission within 30 days, reducing length of stay. If we don't start there and using our data to better understand the populations we're working with, we may start doing all sorts of things that won't have a long-lasting effect, or, well, whether I'll be sitting here in 5 years talking about the next policy, because I've spent time finally on stages saying practice-based commissioning is here to stay when I was at the Department of Health. I helped to create CCGs. They were here for the long term after the 2012 Act. What happened to those? So neighbourhoods have got a potential to be in that arena, no matter what people say, neighbourhoods are here to stay, only if they demonstrate the big impact on the most important thing that the public have always had about the NHS, the public's top concern, waiting and access for care.
Thank you. Yeah, that's really important. I really appreciate what you're saying. But in terms of the digital layer, how do we develop the digital layer to try and trap some of the things that you are talking about? And Charlotte, some of the comments that James has made relate to hospital admissions, delayed discharges and rehabilitation of patients back into community. Do you have tools at the moment that help you look at that? What kind of things do we need to develop?
Yes, I mean, I think the issue is there's no shortage of tools. There are lots of things available. There are lots of systems, pieces of software, data sets that are available and be purchased. I think the first thing that has to be there is the mindset and the parity of esteem and response. Everyone has a responsibility in creating the relationships where that data is shared. I think some of the challenges are that, we're not always in a high trust environment. We're not necessarily always in a commissioning landscape that supports that, particularly with the differences between, say, community services and being attacked by an insect. There we go. Spies from the community sector. And the hospital coming together. And, at the moment, I think I was talking to clinicians last week about could we start using the primary care system to support us better with understanding patients step down from hospital. That's a fifth screen you have to have open. So at the moment, if you're on a ward managing a patient within, Stamford Hospital, Peterborough Hospital, you've effectively got 5 windows open. We don't currently have a modern EPR. We're going through the machine that is the procurement and obtaining that. So we're one of the % against the 100% coverage. And so, you can see why that doesn't happen, right? You can see why there's just a human factor there. That I'm just not going, why would I want to open system 1? I've got these multiple other things if it's not in there. Shared care records, we've tried, where those are available, very highly used in certain settings where they are essential. So if you look at the behaviour where the systems are used and why, you start to understand where the gaps are, a little bit like where your voluntary sector crops up. That's where your care isn't provided, where you see people using the system or being a bit feral in how they use the system. That's where you really need the information. So at the moment, we're having to rely on trust, confidence, and accessibility of other systems. Be interesting to see how the interoperability happens to support that. But it really comes from having a shared understanding of what the best thing is for the patient. And I think, to James's point, having the understanding of harm in the right place.
Yes.
Harm isn't discharging to the community. Harm is holding patients in hospital beds who don't need to be there, or supporting corridor care, which is a daily horror and creates a real concern amongst our staff. So I think the tools are there. We've probably got too many of them. We need to try to rationalise and to bring together our strategies for working with suppliers to improve that.
Yes, absolutely. And Aruna, you were talking about workforce and also patients. So the design of this digital layer has got to incorporate both workforce training and patient acceptability. And obviously, one of the things we were talking about previously was the fact that we are trying to design these services for the patients who are digitally enabled to allow more time to be spent with the patients who are not digitally enabled. So do you want to comment just about workforce development in terms of the use of these tools and how patients could be involved in developing them?
Absolutely. I think we're recognising more and more, aren't we, with neighbourhoods, that the role of agency with our patients is critical in all of this. There is almost you were talking about a mindset to integration across the interface of primary, secondary and community care, but actually there's a mindset of devolution, of being more democratic with your care to our patients. And so for me, I think it's going to be about patient agency and bringing them to the table when we are designing our neighbourhood health. We're integrating with primary and secondary care is critical. Making sure we're talking to them and that we're working with them, I think, has been critical, particularly within the neighbourhood programme in LLR, and is sitting within the in our implementer pilots as well. Designing that, going back to the care plan, so the way that we've approached it is designing that care plan to enable patient agency, which then, and making sure that's a dynamic component of their agency, of their self-care, essentially, has been the way that we're managing it. And I think I'd ask everyone to think about that, because when you are sitting in silo, we talk about siloed working, and we can all talk about interoperability, so seeing each other's records, we're still in silo, but actually having a continuous record across us all that also includes our patients is absolutely critical to that continuity and management of complexity that we're seeing that we're seeing at an earlier age, aren't we? And we're seeing people living for longer with complexity. So I think, to James's point, neighbourhoods will work with all of those outcomes in mind, but the key enabler has got to be patient agency. Within that space as well, we've talked about integrated neighbourhood teams, haven't we? Gosh, the number of times that's the panacea for neighbourhoods. I don't think it's anything new, everyone, right? It's neighbourhood teams. We've been doing this with palliative care for I don't know how long. we've been, particularly as general practice, I think we've been integrating with our community partners as part of our job on a day-to-day basis. But we go back to that element of complexity, and I think that the workforce needs to feel safe, and the workforce needs to feel enabled, because, and so in other words, digital needs to support continuity and holding risk together. So I recognise the harm, but I pivot it, and I wonder whether neighbourhood is actually about integrated risk holding in the community and care through, and delivering that through care closer to home. And that will involve a shift of our consultant experts into an integrated team and that sort of collaborative mindset. So again, it goes back to mindset change being supported by digital rather than it being the digital as the key thing at the beginning.
Yeah, absolutely. So if I could just, conscious of time, and I do want to open up to the audience, James, what is the single most important capability that the NHS needs to prioritise now in terms of digital delivery for neighbourhood teams to succeed?
From the work we're doing with Neighbourhoods, there's the old cliche, we're data rich but knowledge and information poor. I think we just need to clean up the data that we've got to allow us to really understand particularly the primary-secondary care interface, because what we're finding, if we're going to do some work where we're looking at reducing readmissions of a particular condition within 30 days, the hospitals we're working with have said, we can't really tell whether the readmission was related to the first admission or not. So how can you start building a service to prevent readmissions when you don't know that data links? We've got things like MHRA will tell us that 10% of all admissions to hospitals in England at the moment are related to ADRs, adverse drug reactions. Now, we know there's an adverse drug reaction, but we do not know how to deal with them once they've been discharged, because pharmacy doesn't have a contract for ADRs. Practices don't have information that says that admission can be translated back into a practical application in practice. So it's not about just the interoperability, it's linking so we've got proper information that allows us to make a change. And it goes back to the data that allows us to understand the population's debility better and the risk of being admitted to hospital or the risk of getting ill, that we've got to do a lot of cleansing of the data to give us better information. And even if Neighbourhoods did that would be, we're working with some projects that are saying just the fact we know exactly who is at risk, we know their names, their addresses, we can link it between the primary care record and what's happening in hospital. Because at the moment, if somebody goes in with an infective exacerbation of their COPD and is readmitted within 30 days, the hospital is saying, we don't know whether that was because they broke their ankle or whether it was a readmission because of the same problem or whether it was something else. So when we talk about the data revolution, we've just got to get more accurate information, particularly across the primary secondary care interface, and link that. If we get that right, we might start to be able to build integrated neighbourhood teams that have an impact on where the most, where the most impact can be.
Yeah, fantastic. That's lovely. I'm keen to just open up to the audience to see if we have any questions for our esteemed panel. Anybody? We've got a question over there from Tico. Yes, you get on with it. You've got flat shoes on, so it's fine.
Hi, thank you very much. It's really interesting to hear this discussion. My question is, in 2005, I qualified, and we were talking about a single point of record system then. There was a lot of money ploughed in. We've been talking about it every 5 years since then. My question is, why is there not one now?
That's a very good question. Anybody would like to answer that? Aruna, can you take that one?
That's a little bit like what are the barriers, aren't there, to working to integration? I'm sure you can answer a few of those. I think a lot of it is related to our siloed working. I think that, competition, not collaboration over the years. I think we've been moving quite steadily since the 5-year forward view to aligning care as an integrated health and care team, I think, in the community more and more. I think we're going to see contractual change that will align our outcomes, and because we're all sort of living to different outcomes at the moment, aren't we? Sort of general practice is delivering QOF, our secondary care colleagues are delivering their KPIs, aren't they? Our public health colleagues are delivering population health outcomes, and we need to get into a space where actually we have a QOF for all.
Yeah, absolutely.
So I think that's one of the key things.
Charlotte?
Yeah, I think we just need to be really clear on what the story is we're telling that's going to enable. So, what is the vision of linking up this information and helping people to see why that's the right thing? Because a lot of this is really specific, quite boring organisation of work. So even things like making sure you've coded all of your activity effectively so it can be linked together, making sure everybody's naming something in a standard way, making sure you're putting pressure on your suppliers to create. A lot of this is about a sort of a holistic intent to align very much around the same thing and holding the line. I mean, one of the things that works against you is it's incentivised to buy new things, to test and adopt, and to innovate. Whether or not anybody pays you to adapt what you've already got, whether you've got the development time, the expertise within your digital and data team to go back and retrospectively change. Because a lot of the things that stop it happening is, well, we could do that, but the data that's going in is rubbish. How many times have we heard that? That can be fixed. You can invest in sorting those things out, and you have to. And that's my job, is to say, well, actually, before we rush off and do this other thing, how do we get some of that sorted out? So I think once we realised how difficult and complicated some of these things were, because the source behaviours were so disparate, and the diversity of the way the data and things are feeding in, and the underlying infrastructure that hasn't necessarily been fed into, the complexity starts to spiral, the costs and the supplier and commercial management become very difficult. So I think there's something about us getting back to basics in terms of incentivising, putting the foundations in place consistently across all, in my case, providers, and supporting that with resource that will make those things more feasible. Because otherwise, you try and look back into your information and it's not useful. And as James said, no one's thought about coding it at the time of admission, so we can't tell why somebody came in. Like outpatients, still not required to put diagnostic codes. It's like, how crazy if you're trying to change that through advice and guidance. So I think the incentives haven't perhaps been in the right place.
Yeah. Any comments, James?
Yeah, time weren't allowed to tell but I know the history.
No, you're not allowed to.
But I know the answer. One is not to do, you won't been around maybe just NP Fit. Remember NP Fit? Wasted billions on trying to have the one NHS record, so we know how not to do it. Sadly, the way we're going to do it, and I think we're just getting there now, is legislation that requires, Singapore have done it with a national medical record, but they brought law in to say every single provider, whether it was insurance-based, whether it was independent, whether it was private, whether it was state-run, had to, by law, import into the same record or have records that would talk to each other. Now, the commercial pressure is against that, but I think we're going to have the only way we're going to do it is by bringing legislation in, which I think we're close to.
Yes, and that was what was discussed yesterday in the NHS modernisation bill. So you may yet see it. Have we got time for one more question?
One more.
OK, do one from Menti. Well, their energy levels. Look, we've got hands up, Vincent. We don't want energy levels to drop.
Just give the break.
So apologies, we've not been able to answer all of them. I've kind of tried to combine them into a single super question, so apologies for that. So this is a question about accountability. If the digital layer identifies a high-risk patient, preventable readmission, adverse drug reaction, or unmet social need, but there's no commissioned pathway, funded capacity, or contractual owner to act on it, who then owns that risk? And how do we stop Neighbourhood Digital becoming a live register of unmet need rather than a mechanism for actually changing outcomes?
Excellent questions. Who would
Thank
like
all 19 questions that have been submitted.
I mean, that really is an amazingly good collaboration of all the questions. Who would like to start with that one? There's a lot there to unpick.
Can you précis that for us?
So it was about who holds the risk for a patient who doesn't fit a commissioned pathway through the neighbourhood system. So they've had an adverse drug reaction, they've had an admission, but actually, at the end of the day, there is nobody there to pick up their care because that's not been commissioned properly. Where does that risk lie? And I think the other question was also about how you hold risk in this system. Do you want to start?
I will be brief so that in case you want to do another one. So I think this goes back to the thing that I was saying about integrated risk holding.
Yeah.
And this is the bit about the fact that we're going to have contracts that will allow us to think about the needs of our population and the pathways that sit in there that we may end up needing to cater or personalise to communities or personalise to gaps, I think, according to need. And we will get that, I'm sure, if our MNP contracts come through. That's the first thing. I think the second thing then is going to be about aligning incentives and accountability through that contracting, because collaboration will happen. I think in the end, we've got some great examples around nationally where you have collaborated teams within communities holding risk together, but it's taken years. Remember, we've now in our 7th or 8th year of PCNs that have been trying to do that, and it takes a long time if you want to accelerate neighbourhood working and that risk support that we've just talked about, and targeting resources. It's got to be through some autonomy and that devolution through contracting, I think.
Charlotte, you
just to the unmet need point. I mean, we're kidding ourselves, right? If there isn't unmet need out there, or, we're not seeing that. I mean, really. And we've got whole neighbourhoods where we know the number of people who are coming through in demand for care can't be right based on the broader demographics. That would be idiotic if a deprived community in a rural area like that with that level of poverty is only presenting that level. So, I'd rather see it. So I would rather have the data in digital to help explain that and help us to understand and make the right shift decisions in the future. And also, if you sit in hospitals, the main conversation I have with my clinicians every day is they're so worried about the risks they can't see in the people waiting for access to care. It's not, sort out advice and guidance. It's what about all my, delayed follow-ups? What about all of my risk out there in the population? So I think we all feel that risk. So we might as well have a better understanding of where it's sitting. So it might surface some awkward questions for us, but we're big enough and ugly enough.
So I think what we're saying is we need to facilitate the discussions about the risk holding.
Indeed.
So that these questions, we accept that there will be some times where patients fall through the system, as we get now. But the conversations that we have are going to help support that. James, anything from you?
Probably just to say that it usually lands with the identifiable consulting clinician. A very specific aspect of that is on this independent, that's what regulators think. An example would be if somebody goes online, lies about their condition, and receives some treatment as a result of that condition and gets damaged as a result of that lie and the treatment, the problem lies with the clinician at the moment. The litigation will be against the consulting clinician.
Yeah, so that's one to bear in mind as we're designing these pathways so that we can try and adapt for it. Have we run out of time now? Oh, okay, fine. So thank you to my wonderful panellists, and particularly to Aruna, who has stepped in at the last moment. Fantastic. Really happy to